clearly with the return that is coming along imminently. The sessions so far have been extremely valuable, not only for colleagues on the call who are working directly at a national level, implementing guidance and understanding the picture that we face, but indeed we've had very positive response from all of the individuals that have been able to join us so far. We are acutely aware that we can't get everybody onto these calls. There's obviously tens of thousands of people out there delivering education across the country, all doing an absolutely fantastic job. What we would welcome is that that when we do share the recording of this later on with you, that you make sure as many of your colleagues get access to it as possible. And we will do the same. We're sharing it with our colleagues in the unions and in other spaces to make sure it goes out across as many streams as possible. Anyway, without stealing too much of the time, it's my distinct pleasure to introduce our expert panel. This afternoon, we've got Professor Jason Leach, who's the National Clinical Director for the Scottish Government, and I'm sure it really needs no introduction to you all. Jason has become a very well-kent face in Scotland throughout the period of the response. We've also delighted to have Elizabeth Morrison with us, who's an interim director from the Education Directorate within Scottish Government, very closely involved in the work of the COVID-19 Education Recovery Group. And I'm delighted that we've got Dr. Eileen Scott, who is from Public Health Scotland, yet again very closely involved with the work of the COVID-19 Education Recovery Group and is one of the educational recovery leads within public health. They are here to be quizzed by you. I know we've got lots of questions to get through, so I'm not going to take any more of your time. I'm going to pass across to Jason, who's going to do a quick introduction. Thank you.
Simon, thank you so much, and thank you for having us again. This is my fourth public health blether, if my timing is, if my memory is correct. I'm not sure if they've gone upwards or downwards, so we did primary heads, secondary heads, support staff, and teachers. So you can make your own judgment of where you fit in that particular hierarchy.
That's good.
I'm the National Clinical Director of the Scottish Government. I don't walk in your shoes. I don't do your job, but nor do you do mine. So forgive me if I get things wrong or if I get some of the terminology wrong. I understand when this was advertised on Facebook, somebody sent me a little screenshot, suggested there was a sweepstake to see how long it would take for me to mention my wife. Well, here she comes. I mentioned her pretty early on because she's part of the reason I think I have some credibility in talking to this group. I'm not a teacher, but she is. So you can be sure that at the dining room table, when we eat our meals, teaching is very prominent and education is very prominent in those conversations. Quite a number of teachers in my family and extended family. So I hope I have some insight into what you've been doing and how you've been doing it. Just before I show you where we are in the pandemic just now, I want to patronise you. And that patronising is tricky to avoid because I want to thank you for everything that you've done. And some of you may not take that in the manner it's intended, but it is intended very sincerely. I cannot imagine doing this pandemic without our teaching staff. And through the multiple phases that we've been through, and even the phase we're in right now, we genuinely could not do this without you. Both your public health interventions for protecting yourself, your family, the kids and young people you care for, but also the educational elements of that and the challenges that's brought in your schools, in the settings you find yourself in. So please try and take that in the manner it's intended. So let me just spend 10 minutes telling you where I think we are, and then we'll all take questions. Unfortunately, I've brought Eileen and Elizabeth to help because they will be too hard for me, some of them. So they will jump in when it gets a bit tricky. Now, let me see if Teams will do what it's meant to do. I'm never entirely sure why. I bet somebody on this call can tell me. I'm never entirely sure why PowerPoint sometimes comes up as an option in team sharing and sometimes doesn't. So you should now see a slide with mine. I wonder if Elizabeth could unmute and just confirm to me she can see a title slide.
Yes, I can see that, Jason.
Thanks, Liz. So let's have a little think about where we are. We're 12 months on. It's this week, 12 months ago, when we had our first COVID case. On the 31st of January 2020, the WHO declared a pandemic, a global pandemic. And the definition of a pandemic is roughly when it is a risk to every single person on the planet. That's the definition of a pandemic. At that point, on the 31st of January 2020, there were 98 positive tests outside China, 98 in 14 countries. And the WHO have some choices to make. They have to decide when to ring the bell, when to say a thing is a public health emergency, when it is a global pandemic. And those are two different categories. Global public health emergencies are smaller than pandemics, but they make us pay attention. And the WHO declared SARS-CoV-2, the virus that gives you COVID, as a global public health emergency just at the tail end of 2019, beginning of 2020. And to put that in perspective, they've done it 6 times since I've been working for the government, roughly. And you can see the others here. Just go to 2014, Ebola, 28,500 infections globally, almost all in West Africa, almost all West Africans and some aid workers. We got 1 case. So we brushed off our pandemic plan from the wall and we got 1 case. She survived. She was treated at the Royal Free Hospital in an isolation chamber. It killed 11,500 people globally. Now jump forward 5 years to SARS-CoV-2, and it is today 114 million positive cases, 2.5 million dead, at least. These are heavy underestimates. We don't know what's happening in sub-Saharan Africa. We don't know what's happening in a lot of the Americas. I'm sure you were all glued to the First Minister's briefing at lunchtime today. If not, I'll just say one of the things I said there. There are 1 million Europeans caught this virus in the last 7 days. 1 million. Half of Europe is accelerating, half of Europe is decelerating. Now, fortunately, for now, we are in the decelerating half. We are on the downward curve of our second wave, and you can see it here. The orange line is the line to look for. It's the 7-day average. It smooths out some of the weekend testing reductions. And you can see in the last week, in fact, since last Friday, there has been another kind of tip in the curve. So it's just beginning. And it looks as though that's probably as a result of vaccination in the older groups reducing transmission. That's certainly what we hope it is. It also, though, corresponds with bad weather 2 weeks before. So it may be that people stayed in the houses, but it may be also vaccination. If you smooth that out to 7-day incidence per 100,000 people, you don't see quite such a dramatic drop. And that's the problem. The challenge here is we've got a bit stuck at 100 cases per 100,000. Now, in the last few days, that has accelerated. So today, we're down to about 70. The last time we were at 70 was the September weekend, roughly. And the last time we had mortality like we've had this week was my birthday, the 25th of October. And that follows the infections, of course, at the end of September. So we're not out of the woods, not by any stretch, but everything in the data is encouraging. It is hopeful and going in the right direction. Unfortunately, the story now is a story of 2 V's, variants and vaccines. This is a little bit complex, but this is the whole pandemic along the x-axis. The first curve and the second curve, and every colour is a different variant of the virus. Now, there are hundreds of variants of the virus at any one time. Every virus mutates all the time, and most of them are meaningless. Most of them don't change the way the virus behaves. It does exactly the same thing. So you can see wave 1. In July, we get almost rid of the virus, and then it comes back. It gets re-imported mostly from Europe, England, and Asia, and we export it to England, Europe, and Asia, because it's a two-way street, remember, this virus. It doesn't care where you are or where you're from. The pink strip is the Spanish variant, which became the dominant variant in Western Europe for most of the summer and the autumn. And then in late November, early December, the green one arrived, And the smart ones amongst you will have realised that is the Kent variant, B117. More transmissible, but not much more deadly. So it appears to give you the same level of hospitalisation and mortality, maybe just a little bit more, but more transmissible. And more transmissible relatively at all ages. So not that it transmits in kids more than the old one or gives them more disease, but in kids, because it's got an extra transmission advantage, it can move a little bit more. But still safe and doesn't give serious disease and illness in kids and young people. As kids and young people age, of course, the risk increases. Now, this gives us a problem in lockdown and lockdown easing because of this. This is my only complicated slide, so stick with me just for a moment. Blue is when we don't know which virus it is, so ignore the blue line. Red is old virus, so the virus we lived with for 2020, the one we're used to, the one we knew how to manage as we came out of lockdown and then opened things up again. And you can see what happened in December and January. Lockdown on Boxing Day, we locked down some more on the 4th of January, the numbers plummeted. And they plummeted in exactly the same way as they did in April and May of 2020. Lockdown worked for that variant, and we did the same thing again, and it worked again. Now, there are costs to that, which we'll come to in a moment. Green is new variant, the Kent variant, and you can see how much more difficult it is to remove. And that's because it has a transmission advantage. It's the same virus, but it just transmits more easily. So it wins the race. It overtakes all of the other variants and keeps winning until another one comes along one day, we hope not soon, that will beat it. But for now, you can see how difficult and stubborn that is to reduce. And that's what we're facing. That's why it's difficult just now. That final few cases, 500 yesterday, 498 today, just to get that over the edge so that we can get back to some form of normality for families, for businesses, for education. Very quickly, this is the 4 UK countries all aligning at roughly the same point. We were all stuck at that same reduction. Wales is now doing better than the rest of us, but in rough terms, we're all about the same place. And this is the Scottish 7-day incidence, but divided up by age. So you can see the most dramatic reduction is in the 20 to 39-year-old group. They were the most infected, though, in the December easing and the new variant increasing. The youngest age group is the royal blue at the bottom, and that was the lowest number and remains the lowest number. Very few cases and very few hospitalisations and almost no deaths UK-wide. There have been a couple of teenage deaths in severely ill pre-existing condition individuals, tragically. Most of the disease happens in the over 60s and particularly in the over 80s, which is the other blue line higher up on the graph. And that has come down well. That's partly, we hope, vaccination. Which takes me to here. This is vaccination. This is now about a week old, this slide, and we've now surpassed 30%. We've now vaccinated a third of the adult population in Scotland, which is absolutely unprecedented at this pace. We're behind Israel. We're also behind the Seychelles, but they have very few people. But we're ahead of pretty much everybody else. Europe has vaccinated about 6%. So France, Spain, Germany, all around 6% of their populations. But we have now vaccinated well over 1.6 million of our population with one dose. It's absolutely fantastic and going very, very well. It depends on supply. So as supply comes, we will increase that number. And these are the groups. We've followed the Joint Committee on Vaccinations instructions very rigidly, as we always have for the last 3 decades. It would be a very, very brave individual clinically who went against the boffins. The boffins tell us how to do this for the best results for the population. And here we are. We've now pretty much finished everybody over 65 with a first dose. We've done quite a lot of second doses, over 100,000 now in care homes and healthcare workers. And we're moving into what we call Group 6, which may come up in the questioning. And Group 6 is those with pre-existing conditions over 16 years of age. And we're moving into the over 60s. We're aiming to get all 9 top groups, which is everybody over 50, and everybody over 16 with a pre-existing condition that puts them at risk of extra harm from COVID by mid-April. And then we do the rest of the population by the end of July, all pending supply. Now, this is why we do ages and not professions, because your risk is based on your age, not your job. So if you are 90, you need to vaccinate 40 people to save a life. If you are 50 or 52, as I am, you need to vaccinate 40,000 people to save a life. The single biggest risk factor by a mile is your age. And that's why the Joint Committee have stuck with age-related brackets on the way through the vaccination programme. They think that is not only the safest way to do it, but also the most efficient way to do it. And we will have done all of the adults, as I said, by the end of July. Sooner, if we get supply sooner. Now, let me just finish with a broader frame, and then all of us will happily take questions in whichever direction you wish it to go. This is not just about COVID harm. It's not just about disease and mortality from the virus. That is the principal harm we're trying to solve here, but it would be foolish to think what we are doing to society, our response, isn't also doing harm. And that's why today, this afternoon, just before I joined you, I was on what we call our 4 harms meeting. We meet usually about twice a week, and it is the group that forms the advice that goes to the decision makers, the Cabinet and the First Minister, about what to do next and in which order to do those things. And it's based on 4 harms, not 1. Harm number 1 is COVID harm. Harm number 2 is what your response does to the health system, so waiting times, mental health, etc., etc. Harm 3 is social harm, loneliness, educational reduction, closing schools, all the things that this room knows much, much better than I. Well-being of children, caused by not COVID, response to COVID. And harm 4, raw economic harm, unemployment, business loss, gross domestic product reduction, etc., etc. So let me quickly just do a single piece of data for each of those 4. So this is harm number 1. This is mortality. This is death certificate data, different from the data we announce every single day. So this is people who die with COVID mentioned on their death certificate. You can see the 2 waves very, very clearly and tragically displayed on this graph. This is harm number 2, NHS harm and social care harm. So this is postponed procedures on the bottom line. So this is planned operations that have been postponed. The average is the grey line. The reality is the blue line, and you can see how much care we've had to put on hold. We stopped elective surgery. So we stopped doing hips, knees and cataracts because we needed staff and space to do COVID care. But we still do. The top line is emergency care. That's even worse. So that's things that can't be postponed, but that haven't turned up. So that's people not coming with cancer, with heart attacks, strokes, not presenting with disease that they would normally have presented with. Some of it is because people aren't out and about, not crashing their cars, not having as much trauma, but much of it, I'm afraid, is storing up trouble for the future. Harm number 3, there's many graphs I could use for this one. This is social harm. This is just one version of that. This is crisis grants for those who apply in social work departments. So those of you who have worked in this field will know this is quite a high bar to get a crisis grant, and they doubled in the first lockdown and they are rising again in the second lockdown. It's just an indication of people struggling with basic necessities of what they need to do. And harm number 4, very raw economic harm. This is unemployment. Straight unemployment rate in Scotland. You can see we're in Q1 of 2021 and unemployment is predicted to double since the end of last year. And it's the really tricky thing about this slide is it's going to take 5 years to recover. So what we are doing now, I'm afraid, is not short term. It is a medium term kick to the economy. And you can hear in the UK Chancellor's, in the Scottish Government's response this week, some of that playing out and the choices that will have to be made. But my point is that this is not just about COVID harm. It's about much broader societal harm, which brings us to schools and education and early years. So I can tell you for sure, there is light at the end of the tunnel. And vaccination and the reducing numbers are that light. I did struggle to find a slide with light at the end of the tunnel that wasn't a train track, and that metaphor worried me a little bit in case the train was coming to get us. So this is light at the end of the tunnel to an Eden outside that tunnel, which will be a little bit more normal than we've got used to. So I hope that hope is apparent in what we've been saying in the last few days and weeks. We're cautious, but we're hopeful. So thank you for listening. Tedros, who's the WHO Director General, puts it nicer than me. He says the way out of lockdown and the way out of the pandemic is very straightforward. Be safe, be smart, and be kind. Thank you for listening. So let me go back to Teams and stop sharing. Stephanie.
Thank you for that. Similarly to the previous two events, we have a fantastic range of questions. So I really want to thank all the participants for submitting them. They were really great to see in their entirety when I was trying to theme them as best I can. So I don't want to delay anymore, and I'm going to go straight to Heather Fraser, if she would like to unmute her mic, possibly turn on her camera, and she has a question for Elizabeth.
Hiya. My question is, how and in what ways were teachers consulted around the return to school buildings at any point during the school closures and reopenings?
Okay, thank you, Heather. What a great question. And there's lots to this question. And I would also, unlike Jason, who's married to a teacher, I was a teacher. So I really know what it's like in a school. I taught for many years. I've taught in many different schools, from areas of real deprivation in Easterhouse to areas which would be regarded as fairly affluent. So yes, I can claim that I was a teacher, so I do know what it's like in a classroom, which is always useful. So I think that one of the things that we feel is a strength of the way that we've consulted with teachers and other professionals is that we have an education recovery group. Now that's chaired by the Deputy First Minister and co-chaired with Councillor McCabe, who's the convener of the Education Committee from Inverclyde Council. So we have political leaders, but we also have each of the main teacher unions. So for example, the EIS have a place at the table, SLS have a place at a table, AHDS have a place at the table. So we also have representatives from councils, and we have representatives from government. People like Eileen very often attend to give us a public health perspective. And at each of these meetings, then one of the things that is understood by the people that are there is that they have a sort of responsibility to go back to their peers, in the case of the professional association, their members, and actually speak to their members about how they're feeling, some of the things. I'm just sorry, it's very distracting to have the chat coming up. Have some of their, speak to their members and find out how they're feeling. So that's one sort of formal mechanism that we have. We also have, you'll be aware, a science expert group that provides advice in terms of COVID. So for example, Eileen sits on the expert group. One of the other chief medical officers, Marion Bain, sits on the group. And again, we have a head teacher on that group. So again, we get regular feedback from the head teacher about what it's like in the classroom. Gail Gorman, who you'll be aware is the Chief Executive of Education Scotland, sits on that expert group and also sits on the recovery group. And we get feedback through Education Scotland for each of these groups. We also set up before the most recent decision to have a phased return, working group out of CERG, as it's called, or Coveted Education Recovery Group. And the working group was almost entirely teachers and head teachers. And we shared things with them, we spoke to them, and we got information from them. So we have had a range of consultations. Jason also mentioned that I think it's your 4th big Blether, Jason. And in each of these big Blethers, I think this is my 4th as well, actually, we've heard directly from practitioners. We've heard directly from support staff, from ELC staff, and we do listen to them. And I think, making the point about, I was a teacher for many, many years. I still have friends who are teachers. Most of my friends are teachers. And I speak to them and on a very regular basis, which gives me a real route into the classroom that I do listen to. So we do listen to a lot of people in the system. So I don't know whether that helps. As I say, I'm looking at all the things that are coming in the chat.
Yeah. I'm just going to pick up on a couple of those points, actually, because I feel that they're quite important to bring in, and I think Simon's going to contribute as well in a moment. But there's quite a lot of agreement in the chat about perhaps the Education Recovery Group not being consulted before Tuesday's announcement, and similarly with the unions, that there perhaps wasn't enough consultation there, and that within the kind of input we've had so far, that class teachers haven't necessarily been mentioned as a group that were consulted. So Simon, I'll let you come in, and then some of the other panel members might want to come in as well.
Thanks for that, Stephanie. Yes, and I'm sure other panel members will come in, and indeed I know Jason will come in terms of obviously the decision making that's happening through the 4 harms group and so forth. From a COSLA perspective, so the Convention of Scottish Local Authorities, having that direct engagement, not only as Elizabeth has talked to in terms of the Education Recovery Group, but also through our Workforce Issues Group, we are having continual dialogue with our union representatives. Now, clearly in those spaces, we are looking to bring in people from a direct local level experience. We're also making sure that that information is being fed back out to our officers within local authorities, and we know that there is discussions happening through the LNCT structures that we've got as well. So on those basis, we are making sure that we're bringing in as much information as possible as we can from people on the ground, people in the direct services, the experience that you're having. We've obviously got the surveys that the unions have been doing regularly. We also have the workforce surveys that councils have been doing regularly as well, that we continually reflect upon. So we are making sure, and as far as possible, because clearly obviously things are moving at a very kind of fast pace, that we're bringing in these voices and making sure that that is reflected upon in the decisions that we have to make. One of the strong things that we do have to reflect is that clearly we can set a national umbrella for the approach and the guidance that's been taken. It very much does then depend as well about that local level engagement, which we encourage and support as much as possible. But I think to that end, probably Jason can talk to some of the 4 harms work that is going on that drives a lot of the decision making, and Eileen will be able to give some more detail around some of the factors that are put into play there as well.
Two answers to the question, neither of which will satisfy some of the people in the chat, I'm quite sure, and if I were in your position, I maybe wouldn't be satisfied by the responses either. The first thing to tell you is there isn't a universal view from the teaching profession. There isn't a single truth. It is therefore quite challenging to listen to a sector that doesn't have a single truth. That's true of the health sector, it's true of the hospitality sector, it's true of the education sector, it's true of the faith leaders sector that I've spent a lot of time in the last 2 weeks. Some of them are taking us to court and some of them don't want to open. So it's quite tricky. I'm not asking you to feel sorry for me, but it's quite tricky at a national level to make decisions for 5.5 million people and thousands of employees in whatever profession it might be, whether it's education or hospitality or health and social care. So at some level, decision makers are elected to make choices and decisions, and we feed as much information into there as we can using the global research, using the public health advice, and as far as you can, hearing from that sector, be it the leaders in that sector, through the head teachers, the unions, the Education Scotland organisations, and from teachers, classroom assistants, and children and young people, as much as we possibly can to feed that in. And I can assure you those voices are taken very seriously. But at some point, somebody has to decide. Now, I'm very glad I'm not elected and nobody asked me to decide. But the decision makers, including the Education Secretary, have to make a decision about what headroom we've got in our public health pandemic and what to do.
Okay, thank you, Jason. Would anyone else from the panel like to come in on that one?
Shall I come in as well?
Sure.
I think, as Jason has alluded to as well, that one of the tricky things that we have to do is balance harms and risks. And we know that education is one of the fundamental determinants of health, both for children and young people now, but also into the future. And when we're looking at these balances of harms, we are looking at thinking about those long-term impacts, which can also be lifelong. So it's this balance between what's happening with the virus now and the impact that that has in terms of severe illness and mortality, and also these broader harms. And we absolutely recognise that, you know, as individuals, you are doing this really difficult job. It can feel very emotional at an individual level, and that's why the data that we produce and that we look at on a weekly basis is really important. There's a couple of key things that I just wanted to flag from a public health perspective, again, about where you can help us as a workforce. And there are two key studies. One is the COVID antibody surveillance study, so CAS, you might have heard of that, or you might have taken part in it. We had about 30,000 education staff take part before Christmas. And that's where you sign up and you get a blood test come through the post, and you can do that and then send it back, and we will find out what the levels of antibodies for COVID are within the workforce. Now, we saw that the levels of participation in that really dropped off before Christmas and after Christmas. So we dropped between 30,000 people taking part and 3,000. So it's very difficult then for us to understand what patterns are happening if we don't have that data. Likewise, there is the new LFT tests which are available to school staff, and we would really encourage you to take part in that programme if you wish to, because that information really helps us as well to understand what's happening within the school setting. It feeds into the decisions that we make. We know that we've had good uptake. It's been building over the last couple of weeks. And it's really important, if you do your test and you get a positive result, that you take the measures that you need to, and that also you complete the sort of follow-up PCR test. Because what we find is, because the PCR is a more accurate test, that sometimes if you test positive on LFTs, you get a negative PCR test. And it's important. We don't want to be isolating more people than we have to. So I guess that is a different way in which we're engaging with the workforce at a public health at a national level, but it's really important to us. And I think we have engaged really heavily as well from Public Health Scotland in conversations with your union bodies. I join, for example, the Workforce Issues Group with Simon and Coslet every week to give a headline of what the data is telling us and what we think, and again to talk about some of the issues we know that they've raised with us, for example, concerns about well-being in the workforce. And so we're thinking about that and ways in which we might be able to support that moving forward.
Stephanie, you're muted.
Thank you.
I wonder if I can answer one quick thing that's broad from the chat. There's a suggestion in the chat that I think education is risk-free. I don't. I think the only risk-free approach here is to lock everybody in their houses and send them food parcels, and even that would be risky. So risk is a relative concept. It's not an absolute concept. And we closed schools for the first time in history, and we closed schools for the first time in history because the risk was too high. Now, as we come out, as we've done twice now, we think that the health and well-being is at a point at which the risk is appropriate. There is no suggestion that transmission doesn't happen in schools, that transmission doesn't happen around schools, and children can't transmit the virus. I've never said those things out loud, never. I do know that the disease is less severe in children. I know there are less hospitalizations in children, and I know most of the risk in schools is related to the transmission in the community around those schools. We know that for sure. So as transmission and incidence falls, then you can start to open schools and early learning. But there's a point at which, of course, there is risk. We mitigate that risk with as much guidance and instruction as we can, but we rely on you as the educators, as the staff, to help us do that, to both avoid the risk yourself, for your families and your children. But the nature of a global pandemic with a pathogen like this is nothing we open, be it places of worship, workplaces, or schools and early learning, is risk-free.
Thank you, Jason. I'm trying my best to keep up with the chat. There are understandably quite a lot of strong feelings there, and I am conscious of time, so I would invite any of the panel to respond directly to some of the questions there in the chat. Now we're going to move on to kind of drilling into the practicalities of the return, and I would like to invite Maggie Barrowman to unmute her mic and come on with her question.
Hello. How can we protect supply teachers who move from school to school, or teachers who work with multiple groups of children?
And that's for Jason and Eileen.
So I can start. Risk is about number of times you interact with different people and the amount of time you spend with different people. So if it were a football game, let's say, so I've been a lot of chat about the Euros today, and I've had to answer a lot of questions about the Tartan Army. But the fact is that outdoors is better than indoors. Short time is better than long time. Small groups better than big groups. So I wonder if you could just go on mute, whoever that is. That's quite a lot of feedback. So the fact is that if you are a peripatetic teacher, and Mrs. Leach happens to be a peripatetic teacher presently in her career, the less schools you are in, the better. The less new groups you're with, the better. But you can't just go on a Monday, teach one kid, and then never go back for the other 4 days. So there has to be a balance in there about exactly how you do that. So there is a compromise position to keep those bubbles as small and as limited as you possibly can. But at some point, locally, you're going to have to make choices about how that works and how often you do it. And supply teachers is one example, as are some additional support needs teachers, as are additional learning, English as an additional language teachers like Lynn or others. It becomes a local decision-making point for us as we've set national guidance.
Thank you, Jason. Would any other member of the panel like to come in?
Shall I come in? Because I think you'd asked me as well, Steph. So again, I think Jason's covered a lot of what I would have wanted to say there. And just to think about in terms of what we can actually do. And we know that whilst we can't say, you know, it's to this point, you can't break down the sort of what we call non-pharmaceutical or NPI measures into which is the particularly most effective. But we know that there is this combination of approaches which are more effective in terms of preventing transmission in a school environment. And that's combining physical distancing, things that prevent crowding, so coming in and out of classroom environments, particularly with pupils and staff when it's older age groups. And those kind of basic hygiene measures that we talk about, hand washing, cough hygiene, and they have a real role to play in limiting the transmission. And as Jason said, we know that the new variant is a bit more infectious. It's the kind of everybody shifted up the bench. It's like the way the pattern of transmission is the same. It's a bit more infectious for everybody. So actually, the things that we do as individuals in our life and as viruses need to be able to transmit between people. So it's those measures that we can put into place and how effective they are in those environments, which will be really important. I think one of the other things I just wanted to flag in this conversation too, and I think it's just worth saying, what did we see actually, what did we learn in Public Health Scotland and nationally when schools went back after in August, is that, you know, 2/3 of schools had no positive cases of COVID in their pupil population. There was largely, we see among primary schools. We did see that a different picture among secondary schools, where we did see that secondary schools had 2/3 had at least one case, but we didn't see lots of major outbreaks coming from schools. What we tended to see was staff to staff transmission or staff to pupil transmission rather than pupil to staff transmission. Now, the thing with a virus or a variant that's more infectious is that we have to be careful because, you know, it can spread faster, as we saw in the countries. So those mitigations that we take, the things that we put into place, are going to be really, really important. And I guess we can never advise on particular environments because your school environments are going to vary. We'll have very small rural primary schools in the north, or, you know, large scale primary schools like Dunbar. They vary across the country, so it's very difficult to give you specific advice. But as Jason said, you know, the less people that you're in contact with and the less interaction or interchange between those environments, the easier it is to control the virus, and the easier it is for, you know, health protection teams, if there is an issue, to be able to track and trace and isolate the people who need to without having to isolate lots of people unnecessarily.
Okay, thank you, Eileen. There's a lot of discussion in the chat around transmission, social distancing, and also the idea of blended learning. So I'm going to take those in part, and it should be covered by Diane Ritchie's question. Could I invite Diane to ask her question, please?
Right, Stephanie. My question was actually in relation to special schools, because 2 metre social distancing and the wearing of face coverings really isn't practical. I am very lucky compared to a lot of the teachers on here because we do have small class numbers, but even trying to space my desks, it's not going to happen. What additional measures should we be taking?
So the basics are the basics. So again, it's about relative risk. I can't remove the risk entirely unless we close down that school, and we get you to work from home or not work at all. That's the only alternative. So in that space, it's face coverings, distancing, cleaning surfaces, not going if people have symptoms, and now an extra layer of testing for you and the other staff and for older children. That testing has been added recently as we go back because the testing technology has improved. It's not perfect by any means, not 100%, but it's very unusual to give you a false positive. It can give you a false negative, but it's an extra layer. So there isn't anything special that we're keeping a secret that we haven't given you, I promise. So it's all of those things that we all now know and love so well. There's been a number of mentions of appropriate PPE. Sorry, when I don't move in here, the lights go off. So when I'm too still, the civil service tried to save electricity bill, I think. There's quite a lot of mentions in the chat about appropriate PPE. I'm not sure what that means. We have groups that look at PPE globally, nationally across the UK and in Scotland. They are experts on protective equipment and experts on infection and pathogens. That set of boffins, tell us what to do with PPE and what setting. And we have always followed their advice. They keep that under constant review. They look, that PPE is exactly what you get in every workplace that needs it, whether that's an intensive care unit or a nursery.
Thank you, Jason. There's actually, before we move on to Elizabeth's contribution to that, there's some supplementary questions around the fact that the police force are provided with PPE and why are teachers not? And
that's
then
not true. That's absolutely not true. The police get the appropriate PPE for their risk. Education gets the appropriate PPE for their risk. I did this for police recently, and they were telling me that teachers get FFP3 masks and the police don't. So it's not true that the police get FFP3 masks. FFP3 masks are really, really difficult to wear. They're absolutely horrible. Health and social care staff don't wear FFP3 masks unless they're in direct contact with COVID cases with aerosol generating procedures around them. And dentists wear them because they're creating aerosols around them. They're unpleasant and sore on your face. I wouldn't want to wear an FFP3 mask unless I was absolutely necessary.
Can I invite, I can't see your first name, my apologies, M. McDonald, you've made an important point about ventilation. Do you want to come in and ask that question?
Oh, thanks. I work in a high school in a windowless classroom. It's a large classroom, so I'm able to socially distance from the pupils, but I have no window. Keep the doors open and there's a fresh air. I'm told that there's a vent in the ceiling that has connection to fresh air. I just wondered what your views on ventilation and COVID for high school pupils in that environment. Thank you.
So ventilation it's a great question. Ventilation is not one thing. It's not an exact science. We don't have this amount of ventilation keeps you safe. This amount of ventilation puts you at risk. We know that this virus is principally spread by droplets. So it's saliva, noses, coughing, and those in unventilated areas, those droplets, big or small, stay in the air for longer. They drop onto surfaces, whether the room is ventilated or not, and then you can infect yourself or somebody else from that surface. It's just physics. So if you can ventilate the room and move the aerosol generated droplets around the room, then you're less likely to inhale. You're less likely to catch the virus. Therefore, anything you can do to ventilate is better than nothing, but it's not an exact science. So in the middle of winter, opening all the windows was horrid. So opening the windows at the breaks was a useful thing to do. It sounds to me as though you're doing all you can to get that air moving from your door. Air conditioning in that room, for instance, a fan in that room, that doesn't really work because it just moves the same air around. What you need is air exchange. You want the air in and out if you possibly can. With no windows, you can't do that. And therefore, the ventilation you can achieve in that space is to have the door open and clean the surfaces as much as you possibly can.
Thank you, Jason.
So clean the surface. Thank you.
Could I also come in here, Stephanie? The other thing to know is that Scottish Government have given each of the local authority areas significant sums of money to support whether it's ventilation enhancements, whether it's cleaning enhancements, whether it's other mitigations. And actually, if people, have got big concerns, then you have a route through your employer to raise these concerns. You have a route through your professional associations to raise these concerns. And ultimately, you can, I'm very happy to take specific concerns, but if I'm taking a concern, and I'm very happy to do that, it needs to provide details for me, because very often we get comments about, ventilation is not good enough, but unless I know the details as I'm hearing here, then it's very difficult to do anything. But what I can say is that your local councils, your local areas should be doing something about this, because say we've given large sums of money to local areas to do it.
Thank you. There is a question leading on from discussion about face masks. So I'm going to invite Joanna Perry to ask her question, please.
Hi, obviously the impact of the masks for children with additional support needs and also general phonics is detrimental to progression with learning. So how much of our communication is in our face? So for how long do we think that the masks are going to be needed in schools?
Man, I wish I knew. So it's a good question, and I don't want them in there any longer than there absolutely have to be. But until we get transmission down, until we have vaccinated the whole adult population, incidence is falling, we're going to need some level of these, what we call non-pharmaceutical interventions. So the distancing, the cleaning, the hand washing, the face coverings. I hope that we won't need them for too long, but we're going to need them in the meantime. I mean, in the chat, I'm getting accused of not using them enough and of using them too much. It's tricky here to find the middle ground, and that's why the advice is so hard to give. It's an extra layer of protection, but it's not foolproof. It's not in every country in the world. Some countries have done it before us, some countries have not done it, and some countries will do it after us. That illustrates the difficulty with the evidence base to try and make schools and early learning environments as safe as we possibly can. I agree with you that in particular circumstances, then it becomes even more tricky, particularly if you need to see faces, if it's about engaging, particularly in younger children. That's why we've tended to avoid it in younger kids. We have quite strong calls. You may not have missed a couple of scientific debates a couple of weekends ago with a colleague from London and I. She's calling for face coverings in over 6s. In all kids from 6 and upwards, and there is a cry for that from some educational people. We have chosen not to do that in primary schools because we don't think the risk is appropriate, but we've decided to do it in secondary school. You can argue whether that's the right choice or the wrong choice.
Thank you, Jason. I'm going to move on to some questions around transmission and vaccination. So can I please ask Michael Martin to unmute his mic and ask his question, please?
Thank you. So what's the evidence of infection and transmission of the new variants among staff and pupils in primary and secondary schools? And are there greater risks in an open plan school with no dividing walls between classrooms? Thank you.
So we don't know the answer to that question definitively. We haven't had this version long enough, and schools haven't been open with the new variant, remember. So we are the first country in the world to come out of lockdown with the Kent variant as the dominant variant. No country has done that. So therefore, we have to follow that data very carefully, which is why we've said 3-week gaps. Now, the announcement on Tuesday was not these things are definitely happening on the 15th of March. The announcement on Tuesday was get ready for this potential opening on the 15th of March, which we will confirm for you on the 11th of March. That's a very important nuance. And there is a big difference between those two things, because my job, the public health advice job, is to get as much data as we can before we give a go, no-go date to the First Minister and the Deputy First Minister about what's allowed. The nature of transmission, I expect, and we've seen a few cases in Scotland where there has been transmission in some classes since they went back. I expected that to happen. It doesn't appear to be in big numbers. It doesn't appear to be causing serious disease, and that's what we're watching. That's what we're looking at. The R number has stayed below 1. We are reducing incidence across the country. In fact, we have the lowest incidence since September. So therefore, we'll keep watching this week and next week to make a final decision in our advice. Your second question, it doesn't really matter about dividing walls and the containment. It matters about distance between adults and children to some extent, and about the ventilation, the cleaning, and everything else that goes on. So we don't particularly mind if there's partitions or no partitions. It's about keeping whatever environment you happen to have as safe as you possibly can make it.
Thank you. There is another question around transmission about the kind of daily practice within schools and how that affects that. So the question is, what is the true benefit of keeping classes of children separate during outdoor playtimes versus the harm of separating children from friends in other classes? So that's the first part of the question. And the second part is, and what is the true risk of contracting COVID-19 by sharing stationery, pencils, toys and other items versus the impact of harmful chemicals used to clean everything? So it's quite a long question, 2 parts for Jason.
So I think the question illustrates the challenge with the advice. I mean, I'm tempted to say you can't have it always. So half the crowd want one version, half the crowd want another. So the reason we try and keep the bubbles as consistent as you can is to reduce the number of times kids interact with other groups of kids, because then the transmission risk increases. It doesn't go away in a smaller group, but it is easier to manage. It's also easier to manage if you have to isolate a group of children because there's a positive case or a positive adult or something happens in there. So that's why the bubble concept became apparent with classes or groups. And that's really challenging. I cannot begin to think about how difficult that is when you then let the kids out to play and you have to stagger the breaks and you have to stop Frank playing football with Gary because they're in different. I mean, that's just horrible and really difficult. And the sooner we can remove it, the better, frankly. Now, Stephanie, I was reading the chat, so tell me your second part of your question again. You're muted.
Not very good at this, Emma. The second part was around what is the true risk of contracting COVID-19 by sharing stationery, pencils, toys.
Okay. So again, that's very, very hard to be explicit about. The virus likes shiny surfaces rather than rough surfaces. It doesn't survive well on fabrics. It survives well on shiny glass or shiny plastic desks. It's not impossible the virus could transmit from equipment. So that's why we ask you to wipe that down. You shouldn't be using harmful chemicals to clean everything. You should be using very, very simple disinfection. Alcohol gels, just soap and water, anything. The virus hates anything that rubs it. So anything that gets rid of it is good for you and bad for the virus. The virus doesn't like even just wiping down with soap and water. So you shouldn't have to use anything too tricky. You don't have to bathe your pencil sharpeners in something horrible from a hospital in order to make it clean.
Thank you. We have one more question around transmission. So I'm going to invite Nuzat to come in with her question, please.
Hi there, everyone. My concern is regarding our BAME communities. In February, it was reported that up to 100 children were being hospitalised every week in England. 75% of them were children from ethnic minorities. I have felt that ethnicity data has been greatly lacking within Scotland, and I think very little has been done specifically to protect those communities, children and adults, despite knowing that they are at high risk. So my question really is, where is this data in Scotland? Why is it not being shared? How can I access it? And what are you doing about it?
Hi, it's a great question. So there is a huge amount of work globally about risk and COVID and ethnicity. And some of it is not clear and some of it is a little bit more clear. We don't know and fully understand that risk, either its scale or why it exists. Most of the literature from Public Health England and from Public Health Scotland suggests that the ethnicity risk is related not to any biological reason, but is related to pre-existing conditions, housing, other socio-demographic reasons about where particular ethnic groups live and our inability to get healthcare and other things to them. Not them, our fault, not theirs, of course. It is not a biological problem in East London, where the Bangladeshi community was very badly affected by COVID, or the Orthodox Jewish community very severely affected by COVID. That then changes how you have to respond to that. You have to use trusted leaders, you have to use trusted voices to go and do that. We haven't seen big ethnicity changes or disparities in our COVID admission data or our COVID ICU data. We do think there is an increased risk of catching it because of the nature of the socio-demographics, and then you get more severe disease because there's more diabetes, there's more underlying conditions in some of those communities, particularly the Southeast Asian community, but not uniquely to it. And I'm branding it as if it's one big group. It of course isn't. There are lots of diabetic white Scottish people who are also suffering a great deal from this disease. Public Health Scotland has published a couple of evidence papers on exactly this. Eileen will have to help me if there's been anything specific on teachers and kids. I don't think there has, but she'll be able to help me. The broader point is absolutely right, and the individual risk assessments for teachers, for additional support needs kids, for the environments should take ethnicity into account, but the scale of what that ethnicity means is quite hard to quantify for everybody, including us. Eileen, can you help me with anything else?
Absolutely. So just to pick up on a few points there, Jason quite rightly said that we have been publishing data because I think it was a really important thing for us to understand the impact of COVID in BAME populations, for exactly the reasons that we know that there is deep-rooted inequality in terms of access to health services and health outcomes. Colleagues published on the 3rd of March. It's in this week, so we have a weekly COVID report, which gets published on a Wednesday. And I will share the link in the chat. So the latest report was published on Tuesday, so the 3rd. And it looked at, in terms of risk for other populations. And it did suggest that while rates of hospitalisation or death were higher across the second wave across the whole of the population, those of the South Asian ethnicity, as Jason's alluded to, were at proportionately greater risk. Now, in terms of children and young people, you asked that question about that data. I think it's a good news story in some respects for us in Scotland in that we have not seen huge levels of hospitalisation or poor health outcomes for children and young people. That's actually been extremely low. So if I was to give you the numbers, so from the start of March last year, we've seen 110 5 to 14-year-olds admitted and 105 15 to 19-year-olds. I think there's slightly more 0 to 4-year-olds. It's 184. And the reason for that is obviously with very young children, there's a precautionary principle because you don't want to risk that something very bad's going to happen to them. So actually our numbers have been really low. So again, on the Public Health Scotland dashboard, you'll see it's what we call an aggregate graph. So it totals up these numbers from the start of the pandemic, because actually on a weekly basis, the case numbers are so low that they become individually identifiable. And so we have a responsibility to protect individuals in terms of their health. It is something that we're interested in looking in further. So I mentioned the CAS survey earlier. We have a small proportion of that survey are people from BAME communities. We are encouraging everybody within the teaching and education workforce to take part in these studies, because the more people who take part in them, the better our understanding, so our ability to answer those questions. Again, I would though refer to one of the studies that we have done is look at, so we can link data sets because we hold the health data sets. So we sought permission from General Teaching Council for Scotland to get teacher registration data as well. So we take these anonymised data sets, link your CHI number, which is your health index number, plus your teacher registration number, and then we can look at across the whole population and compare the teaching population to the rest of the population. And also we compared it to healthcare workers because we know there's additional risk, and we didn't find any additional risk really, and that's consistent across countries when they've looked at risk in the teaching workforce. Again, it may be worth us having more in-depth analysis looking at it. We don't think there's anything looking at that in terms of ethnicity, but as we get more data, and particularly in light of the new variant, we'll keep running that analysis to see if that pattern changes.
Thank you. Can I just come back in just very briefly? Yeah. Thank you, Jason and Eileen. From a teaching point of view, we are a very small minority, obviously ethnic minority teachers within the workforce anyway. I helped to lead the EIS's BAME network, and I helped to develop our individual risk assessment. As far as I'm aware, it's the only one that exists, and it's a continuous challenge to get school leaders to recognise it and put it in place and give it the importance it needs. So I think something like that, if that had come from the directorate, for example, it would be useful so that everyone understands that the risk is there and it's not a burden on us to keep trying to push for it. So, if any of you want to connect with regards to any more information in that, I think it'd be really helpful.
Certainly, I think from Public Health Scotland perspective, that's something that we would really welcome, and further discussion around that. that community. The other thing I did want to mention before I forget about this data and dashboards, that we realise it's quite hard sometimes to find this data. I'll talk about it, but you know, I find it hard to find it sometimes. So we are going to publish, we're going to make the proper announcement next week, but in the coming weeks there's going to be a special education dashboard which is going to have much more of the sort of data around schools, children and young people, so that we'll make sure that that link as well gets circulated through the unions and workforce reps so that teachers know where it is and it's easy to access.
Thank you.
Thank you both. Just before we move on, there is a lot of agreement around thanks to the panel for answering the questions so far, and grateful for the opportunity to have this conversation and the wish to have more of these types of conversations. We're going to move on to some questions around vaccination now. Jason, I know you have to leave us shortly, so we're trying to squeeze as many questions in as possible. If I could invite Louise to come in with her question, please.
Wondering if you mean me?
Louise, sorry, Light Owler.
Right, okay.
Hi, good afternoon. If teachers were prioritised for vaccination, although not necessarily an at-risk group, would this not lessen transmittance and length of illness and facilitate schools staying open and therefore consistency of delivery and learning? Thanks.
Hi, yes, it would potentially do that, but who would you take the vaccine from? So that's the fundamental question that the Joint Committee on Vaccination had to answer. So yes, it would potentially reduce transmission for you as an individual, but who would you take the vaccine off? Somebody at higher risk than you of death and disease from the virus. We don't have 9 million doses of the vaccine. If we did, we would do the rollout differently. We have 30,000, we then get 17,000, we then get a few more. So we do about, just now, about 30,000 a day. We've been up to 400,000 a week, almost a couple of weeks ago, and we are coming for everybody. And a number of teachers and support staff in schools have already been done because they're caught by the categories I just described. But the Joint Committee on Vaccination, and I completely agree with them, is that they say do ages. Work your way down through ages. There aren't a number of vaccines turned down every day, Mrs. Uthmani. We fill our appointments. Of course, there are some people who don't turn up, but we give them to the same category of risk people who are in there. We waste a very, very tiny amount of vaccine, which is inevitable in a program, the biggest vaccination program in history, but we use pretty much every drop of vaccine that we possibly can. All of the risk at this point in the vaccination program is about death and disease, not about transmission.
Thank you. There was an additional side to the vaccination question, which was around vaccinating teachers who work with very young, vulnerable children and teachers that have a high COVID age. So I don't know if you want to add anything there, Jason, around that.
So the Joint Committee on Vaccination are the UK experts on vaccination, and they've looked at all of the available evidence of risk of COVID and the ability for these vaccinations to do that. So they have decided that the way to do this is risk-based age bands, with two exceptions. Health and social care staff who are looking after COVID patients, who are in environments where we're trying to protect the individual, not the nurse. The 24-year-old nurse is being vaccinated, not to protect the 24-year-old nurse. It's to protect the 85-year-old lady she's looking after. That's the key difference with that occupational exemption. And risk goes up with pre-existing conditions. So COVID age is not something we recognised in the literature. COVID age is an internet-based thing. It bears no relation to the actual risk-based judgments that are being used inside the Joint Committee's assessments using the research which we've done around hospitalisation, death and severe disease. That's based on the diseases that give you that. And that takes us to the controversy around asthma. And I completely understand. I have family and friends who are concerned about that choice, but it illustrates the point. The Joint Committee, looking at the evidence, have seen that if you have oral steroids, so if you have severe asthma or a hospitalisation, you are more at risk of COVID and severe COVID than the general population. If you are a well-controlled asthmatic, your risk is no higher than the general population. Therefore, we take the top group, we give them the vaccine as a priority, and we don't give the other group vaccine as a priority. Let me just remind you, though, that we're going to do all over 50s by mid-April, which is only 5 weeks away, and we're going to do all over 16s by July. So we're coming for you, and if you lived in any other country except Israel, it would be slower.
Thank you for that. There are some additional comments in the chat that you might wish to kind of answer there, Jason, but I'm going to move on for the moment because I'm conscious of time. Could I invite Annette to ask her question, please?
Hi, Stephanie. This is a question on behalf of one of the participants, and it's asking, how are the Educational Recovery Group monitoring the effectiveness of the mitigations in place in schools? And I think that also rolls into some of the comments we had earlier in the chat pane about the decisions around blended learning. So maybe a little chat about that would be helpful.
Elizabeth, do you want to come on this one, please?
Yes, thanks very much. And thanks to whoever submitted that question. So I think there's a few things to cover here. The Health and Safety Executive visited around 50 of our schools earlier this year. And on the whole,
500, Elizabeth.
Was it 500?
500, yes. I think, yeah, it was 500 that they went, yeah.
So, sorry, my apologies. 500, I thought it was 50, but 500 schools, which is a fair percentage of the number of schools in Scotland. And actually, overall, they found that the mitigations that had been put in place are actually very, very good. And they identified some really innovative practice, which was then shared. So we do have a report from the Health and Safety Executive who actually looked at all the mitigations and then, as I say, wrote it up. And what was striking was the way they commended the work of all staff to actually put these mitigations into place. So that's one thing. And if you like, that's independent of the Education Recovery Group and independent of councils, which is a really strong example of visits. There was the odd school that they went back to, but it was very much the very odd school in that. Local authorities, as employers, and I'm sure Simon may say more on this, have a duty to actually ensure that mitigations are taking place and are in place. Again, we take feedback from the professional associations at regular intervals about the mitigations that are in place or not in place. And I think one of the things that I would comment on is that I know that there was comments in the chat about the number of schools that had been closed because of outbreaks and things. In point of fact, that I think it's 13 schools closed as a result of outbreaks. We actually had very, very few, and to the best of my knowledge, no schools have been closed since Christmas. Now, I know that we didn't have many children in schools in terms of until last week, but actually, I don't think any have. If somebody knows better, I'm very happy to be corrected on that, but I don't think we've had a single school closed since Christmas. And as far as I'm aware, it was 13 before Christmas. So we have not had large numbers, and that's because the mitigations are in place. And in the whole, people are absolutely following them really, really well. So for us, that's a sign that the mitigations are being followed. So there's somebody coming in saying 2 schools in my town alone this week closed completely. Very happy if you give me some more information, Emma, to follow that up.
And so I suppose the second half of that was about remote learning and blended learning. Elizabeth, if you could say a wee bit about on the decisions not to go with blended learning at this point. There's been a number of comments in the chat about that.
Well, I think as we've been saying that on the whole, schools are low risk environments, and particularly for primary schools. And I don't want to go over stuff again that we talked about earlier and Jason mentioned in terms of low risk environments. In terms of secondary, then secondary schools will continue to have remote learning. We've been very clear that 2 metre distancing between staff and pupils, and between pupils will be required at the secondary stages. And therefore, we all know that we cannot have the full roll back at the same time. So there will be an element of blended or part-time or remote learning continuing. So it will continue. What we also know from all the evidence is that the quality of remote learning has absolutely massively improved. And again, to me, that's a real credit to every single teacher that's been delivering that, because we're hearing that from everybody that the quality has improved.
Thanks, Elizabeth. I'm sure that's really helpful.
Thank you both. We are moving into our final area. Of course, there may be more, and I would encourage people to put any final questions in the chat pane. We have around 5 minutes left. But our last question, again, Annette, if you could ask that on behalf of the participants, please.
Sure, Stephanie. There's been a lot of discussion around the legacy of children and young people's mental health following the pandemic. How will mental health support be provided to pupils and staff in the aftermath of the pandemic? From one of our participants.
We can have Elizabeth and then followed by any other of the panel members, please. Oh, Elizabeth, you're on mute. You're still on mute, sorry, Elizabeth.
You're off. There you go.
Sorry, I'm really sorry. I was trying to follow up Emma's name so I could actually get back to her to find out some more details, and I missed the question. So I'm a really bad person.
I'll repeat it. No, don't worry, I'll repeat it. There's been lots of discussion around the legacy of children and young people's mental health following the pandemic. How will mental health support be provided to pupils and staff in the aftermath of the pandemic?
Thanks very much. And I think this is an area that all of us are really concerned about. And I don't think it's unique to children, staff working in schools. I think it's a concern as nationally about the impact on our mental health and well-being. If we look at staff first of all, and the reason that I'm mentioning staff is that David earlier put quite a lot of information in the chat on what is being done to support mental health of staff. And I think that it's probably miles back on the chat because the chat has been very active, which is great. But David could maybe post some of these resources and may talk about that again. If we think about the mental health of our young people, then that was absolutely critical. And when I say that, many of the discussions about bringing children back to school was actually because of protecting mental health and actually enabling them to do an element of socialisation, where if they're in their own homes, they're not getting that same element of socialisation. So actually that was a key area that we really thought about, because we really felt that we had to support the mental health of young people. And we're also looking at if provision can be put in, for example, over the summer in terms of supporting mental health. And that's before anyone says that's not expecting teachers to provide that, but actually look at what other support could be used to actually provide that. And certainly in schools, it's this focus on mental health. And we know that teachers are very adept at responding to the mental health of young people, and that nurturing approach that we see in so many of our schools. And actually it's about following that up. So I don't know whether David wants to say anything in terms of mental health support as well.
Yep, David, would you like to come in, please?
Sure. So hi everyone, I'm David Burgess. I'm part of the professional learner leadership team, and we've been supporting the work from the funding from the Scottish Government around Workstream 6, which is strengthening this support for the workforce. And I put in some links in the chat pane that the funding came in, and there's been a focus around a couple of areas. We've got working with partners Place to Be and Barnardo's with a particular focus on supporting staff. There was an awareness of the kind of demands and the pressures that people might face, but also in return to schools. This is going back to August time, recognition that there might be kind of support required around that. So there was 2 offers from Place to Be and Barnardo's. There's Place to Think webinar sessions to bring people together. Barnardo's are looking at a cluster approach, bringing groups of staff together to create environments where people can talk, share and explore and discuss, because that sense of almost supervision of having a chance to actually offload to share is really, really important. There's also coaching offers, so coaching from Know You More, and that was offered to head teachers at the outset and then was widened to those who have got responsibility with child protection, also those who are new in role, new in post, and also we had support for post-probation teachers, so years 1 to 4 from the Stepping Stones programme as well. Now that funding's been approved again for next year, so what the group will be doing, we'll be looking at evaluating impact of that and also identifying any gaps that exist currently. So looking to expand that and develop it. But the key bit is also about making it sustainable. So taking the best from that to support the profession ongoing. And there'll be a big focus on coaching and mentoring within that as a support mechanism for staff. I've put in links in the chat pane to those information. One of the links is a PDF, but that will become a web page. But that is not just Workstream 6, that is all supports that have been identified across local authorities as well. So ADES colleagues, the Association of Directors of Education in Scotland, had identified supports in local authorities. And it's important to stress there will be lots of supports in local authorities as well. And it's just, so there's just some links now, because some of the feedback is sometimes it's difficult to find things. So we're trying to kind of make that as easy as possible to support everyone.
Can I maybe just echo that, Stephanie? Is obviously I think one of the critical things is whilst we're putting some excellent resource in at a national level and supporting the work that's going on the ground, as we've said earlier in the chat, for a number of these areas where particularly anxieties are high, you know, engagement with your line manager, engagement with local HR teams, health and safety teams and so forth are critical, because actually there are a lot of things that are in place, have been in place for a long number of years as well and available to staff. And it's often only when you need something that you realise actually what's been there for you. So please do reach out locally, use local intranets or other newsletters that are available to you and the rest, and you will find that there is a range of supports that can help you and indeed others that may need support.
Thank you, Simon. Unfortunately, we are running out of time. Before I pass to the panel for any final comments, I just want to say a huge thank you to all the participants. It's been a really interesting and appropriately challenging questions, I think, as well in there. I'm sure we could be here for several more hours to go through them all. But what I will put in the chat pane is a link to an evaluation. And if you have enjoyed this opportunity and you would like more of them, we would really like to hear about it. We are very keen to provide more of these opportunities, so having your agreement on that would be helpful. So I'll put that in the chat and I'll hand over to the panel for any final comments before Simon closes the session.
Can I just come in on the mental health aspect as well? And it's an area that's dear to my heart. I mean, I'm public health, but actually my background originally is clinical psychology. I trained as a clinical psychologist and I worked in CAMS. And one of the best bits of my job was actually working with schools and working around preventative work around, you know, the support and the simple things that we can do in each other's lives actually to support mental health and well-being. And that's the simple things of being kind and considerate to one another. And I think there's just recognising that all of us, so all of you, all of the young people and children that you work with, all of the people around here have been through a collective trauma. And that's going to take time for us to get over. But we know that the vast majority of people will. It's just that, you know, often the people who are struggling in the first place are going to be the ones that fall a bit further behind. The children who had problems with communication before they went to school are maybe going to have greater problems. So I think there's a huge amount of value in actually just kindness in our day-to-day work and recognition that actually it's been incredibly difficult. You are doing a brilliant job. It will get better, but it's going to take some time, and most of us will be okay.
Thank you, Eileen.
So Stephanie, I'm going to go next because I'm about to be on Radio Scotland. So I apologise for having to disappear quickly, but as soon as their news programme is finished, I'm about to be interviewed, and it will be easier than this, let me tell you. I hope on a Friday evening on Radio Scotland. But thank you for having me, and I appreciate everybody's concern. I ask people to be kind, both to each other, to different views, and I promise you that our motives are good. Our motives are about those 4 harms, which include the death and misery from COVID, but they also include the well-being of the children and young people of our country and the well-being of our school staff. And everything we're doing is trying to balance all of those things together. And we're not going to get that right every time. And we're certainly not going to get full agreement every time. But the nature of these national jobs is that sometimes we have to make choices that perhaps not everybody here agrees with. So thank you for having me. I think that's us reached the end of the 4. Maybe we start that cycle again, do we? But once something changes. So I'm gonna drift away. I'm sorry, Elizabeth, not to hear you and Simon, but I have to go do media.
Great. Thank you. Bye, Jason.
Thanks, Jason.
Can I just thank everybody very much? And as I think I mentioned, you know, I was a teacher for many years, and I mentioned that I still have very many friends who are teachers. I'm meeting on Zoom tonight. One of my best friends who's a teacher. I wish, like everybody else, I could see her in person rather than on Zoom. And we do listen, and I do listen to what people are saying, and I would like to say how much I admire what everybody's doing. And I know that in many ways people think it's easy for me to say that because I am, you know, sitting at a desk most of the day. I'm not out in a classroom, but I do try and keep my feet on the ground and remember what it's like, being with young people. And I think that all of us go into the profession to make a difference for young people. It's certainly why I made the decision to become a teacher. And I think that, you know, the point that Jason made is that we do have to make recommendations. We do have to support sometimes difficult decisions. And what we're doing is we hope for the best, and for the best for our young people and our nation. And thank you very much for all your questions and for all the chat that I just couldn't keep up with. Thank you.
Thanks for that, Elizabeth. I'm not going to keep everyone any longer. I appreciate it as a Friday night. There is still some light in the sky, and you'll all be wanting to get some fresh air from wherever, or indeed travel home and the rest. And I wish you a safe journey home. Can I thank everyone absolutely for your honest questioning and the rest? The panel do value it. This is important. We are listening. We are trying to respond in as many and as best ways as we possibly can. And it's only through having such sessions as this that we can do that. There is obviously a great deal of local flexibility, a great deal of local variation. That's what we keep emphasising. So when you hear messages nationally, don't take them absolutely as that will be what's happening on the ground, because it won't necessarily be, because there will be those decisions to be made about your own circumstance, your own school setting, the young people that you're working with and the rest. So please do always bear that in mind. But if you've got any issues, as I say, please reach out, not only locally to your line managers, your health and safety departments, your HR departments and other people and the rest, but also please share the messages that you've been hearing today and the rest. And when we share with you at the end of this, not only the evaluation, give us your honest feedback, because we will do more of these sessions where we can, but also please share the video of this session as well, because hopefully that will help other people understand clearly what is going on across the country. Thank you all very much again for your time. Thank you to our panel, to Jason who's left us, to Eileen and Elizabeth who've been here. Thank you yet again to Stephanie for your excellent stewardship through the session and the rest. And thank you to everyone for all of your questions. We'll be in touch with all of the links so that you've got those and that you can share them as widely as you can. Have a good night.